Usually a broken bone is pretty simple, right? You see a jagged white line on an X-ray, you cast it, and you're done. But fixing a skeleton from the inside out is, well, way more complicated. Welcome to today's deep dive.
Yeah, thanks. We are looking at a massive textbook chapter on osteoporosis today, but specifically focusing on the pharmacological arsenal, the actual treatments.
Right, because we aren't just telling you to, drink more milk. We are talking about literally poisoning your body's cellular demolition crews.
Exactly.
Or forcing patients to stand at rigid attention for 30 minutes just so they don't chemically burn a hole in their own throats. It's intense.
It really is. I mean, to grasp the strategy behind all these therapies, you have to realize that your skeleton is never actually finished. It's this bustling, microscopic construction site.
Okay, so you have the demolition crew, right? The osteoclasts.
Yep. The osteoclasts are constantly tearing down old, damaged bone tissue. And then hot on their heels are the osteoblasts, the builders. They lay down the fresh, flexible new bone.
So it's just a constant loop of demolition and construction.
Normally, yes. But in osteoporosis, that balance just totally falls apart. The demolition crew basically goes rogue. They're working significantly faster than the builders could ever hope to keep up with.
Which means all the treatments we're unpacking today have to do, well, one or two things.
Yeah.
Either drastically shut down the demolition or put the builders into absolute overdrive.
Right. But before a doctor deploys the heavy pharmaceutical artillery to do either of those, they have to secure the supply chain. I mean,
Yeah.
you can't hire a construction crew if you don't have bricks and cement on the site.
And in the human body, calcium is the brick.
Exactly. And vitamin D is basically the site foreman. It's the chemical key that actually unlocks the intestinal gates so that calcium can get into the bloodstream.
Okay, let's unpack the supply chain for a second. Because my immediate instinct, and probably the instinct of anyone diagnosed with bone loss, is to just overwhelm the system.
Right, the more is better approach.
Yeah. Like if you need calcium to build super bones, why not just swallow a massive handful of supplements every single morning?
Well, your gastrointestinal tract aggressively rejects that kind of brute force logic. The source material highlights a pretty hard biological bottleneck here. Your gut can only absorb maybe 500 to 600 milligrams of elemental calcium in a single dose.
Wait, really? So if you take a massive pill, the rest is just...
It's just wasted. The body stops absorbing it. For adults, the daily recommended intake is about 1,000 to 1,200 milligrams of calcium and, 800 to 2,000 IUs of vitamin D.
So pushing way beyond that doesn't help at all.
No, actually, pushing your intake far beyond those limits doesn't give you denser bones. It gives you hypocalciuria.
Which is a fancy way of saying dangerous calcium-filled urine.
Yeah, essentially. You end up with dangerously high levels of calcium in your urine, which massively increases your risk of developing debilitating kidney stones.
Yikes. So definitely don't do that. But the text also mentioned a really strategic catch when it comes to buying just like over-the-counter calcium.
Oh, the carbonate versus citrate issue? Yes. This is a crucial clinical pearl.
Right. It's not just about how much you take. It's about stomach acid.
Exactly. So the most common cheap form of calcium on the shelf is calcium carbonate. Things like Tums or Oscal. It's great because it's 40% elemental calcium, but it absolutely relies on a highly acidic stomach environment to break down.
So if a patient is taking, say, a proton pump inhibitor, like a common heartburn medication,
They've fundamentally altered their stomach's pH. They've basically turned off the acid.
meaning that calcium carbonate just passes right through them. It's totally useless.
Precisely. Those patients absolutely must be directed to take calcium citrate instead. It has a lower concentration of calcium, sure, but it doesn't need an acidic environment to dissolve.
Wow. That level of detail is exactly why treating this is so tricky. But okay, let's assume the supply chain is fixed. Raw materials are flowing.
Right. But the rogue demolition crew is still actively tearing the building down.
Yeah, so we need to shut them down.
Yeah.
Which brings us to the frontline defenders, right? The bisphosphonates. How do these actually stop the demolition?
Well, bisphosphonates like alendronate, which is a 70 milligram oral pill taken once weekly, are basically a marvel of targeted delivery. They have this massive affinity for calcium.
So they act like homing missiles for the bone matrix.
Exactly. When they enter the bloodstream, they embed themselves directly into the skeletal architecture.
Oh, so they just hide in the scaffolding.
Yep. So when an osteoclast comes along to break down that piece of bone, it ingests the bisphosphonate. The drug then poisons the osteoclast from the inside, triggering cell death.
The demolition crew literally eats a poison pill. That is brilliantly insidious.
It really is.
But the administration rules for the oral versions of these drugs are notoriously brutal. I mean, the text stresses that you have to take the pill after an overnight fast with plain water and then stand at rigid attention for 30 to 60 minutes.
Yes, sitting or standing completely upright.
Why are the conditions so strict? I mean, who wants to do that every morning?
It comes down to bioavailability and tissue toxicity. So first, orally administered bisphosphonates are incredibly poorly absorbed by the gut. If you have even a trace of food or coffee or orange juice in your stomach.
The drug just binds to that instead.
Yeah, exactly. It binds to the food instead of entering your bloodstream, rendering the dose completely useless.
Okay, that explains the fasting and the plain water. But why the enforced standing up part?
Gravity. These specific chemical compounds are highly caustic to the mucosal lining of the upper GI tract.
Oh, so if you lie down.
If you take the pill and then lie back down in bed and that medication refluxes back up into your esophagus, it can cause severe esophageal erosion, like intense inflammation and ulcers. Gravity is the only thing ensuring that pill drops straight down and stays there.
I can easily see a patient just refusing to deal with that whole ritual. Is there a workaround?
There is. The text mentions zoledronic acid, which is an intravenous alternative. You get a 5 milligram infusion maybe once a year, and it bypasses the stomach entirely.
That sounds way easier. But it's not a free pass, is it?
No, definitely not. 4V delivery avoids the esophageal burns, but it triggers an acute phase reaction. Because you're dropping a huge, potent dose straight into the blood, the immune system thinks it's under attack.
Oh, so you feel sick.
Very. Patients often get intense, flu-like symptoms, severe muscle aches, joint pain, fevers. It can last for days after the infusion.
Man. And beyond those immediate reactions, we have to look at the long-term biological consequences here. We're talking about permanently embedding poison into the skeleton.
Right.
And the textbook warns about some genuinely terrifying long-term risks, specifically osteonecrosis of the jaw, where the jawbone literally dies, and atypical femoral fractures.
Yes, where the thickest bone in your body just snaps in a highly unusual way.
But wait, if the drug is stopping bone loss, why is the bone snapping?
That gets to the heart of why bone remodeling exists in the first place. Everyday walking and living creates microscopic cracks in your skeleton.
So the demolition crew is supposed to clean those up.
Exactly. The osteoclasts clear out the microcracks so the builders can patch them. But if you aggressively suppress the osteoclasts for a decade with bisphosphonates,
You stop the bone loss, but you also totally freeze the repair process.
you freeze the repair. The bone becomes denser on an X-ray, sure, but the material itself becomes brittle and structurally fatigued over time.
Which leads to those bizarre fractures in high-stress areas like the femur or the jaw.
Exactly. To mitigate this, medical guidelines demand a high-stakes strategic maneuver called the drug holiday.
A drug holiday.
Mm-hmm.
So you just stop taking it.
Basically, after a patient has been on oral bisphosphonates for about 5 years or IV therapy for 3 years, the doctor will intentionally pull them off the medication.
Because the drug is already embedded in the bone, right? So it keeps working a little bit.
Right. It continues to release slowly, providing some residual defense while finally allowing the bone to, breathe and do some much-needed micro-repair. It's a calculated gamble.
Walking a tightrope between allowing repairs and preventing massive bone loss.
Exactly.
Okay, but what if a patient can't do bisphosphonates at all? Like they get the esophageal burns and their kidneys can't handle the IV infusion. We can't just let the demolition crew run wild.
We can't. So we shift our strategy. Instead of poisoning the workers on site, we intercept their communication network.
Enter denosumab.
Yes. Denosumab is a biologic drug, a monoclonal antibody. It's a 60 milligram subcutaneous injection given every 6 months.
And the mechanism here is entirely different. The text focuses on this protein pathway called NAKL.
Right. NAKL is essentially the chemical work order that tells the body to mature pre-osteoclasts into fully functioning demolition cells.
So what does the drug do?
Denosumab binds directly to NAKL and neutralizes it. It's a decoy receptor. You are essentially cutting the phone lines.
So the signal never reaches the cells, and the demolition crew never even shows up to the site.
Exactly. It is incredibly elegant. You don't have to poison anything.
But because it doesn't embed in the bone like a bisphosphonate, the logistics must be totally different. Like what happens if a patient misses that 6-month injection?
It triggers a catastrophic rebound effect. Since denosumab stays in the bloodstream and soft tissue, its effects are entirely reversible.
Wait, so if that 6-month window passes,
The suppressed communication network suddenly roars back to life. A massive wave of osteoclasts matures all at once, leading to an accelerated dramatic loss of bone mineral density.
Oh, wow. A completely reversible trapdoor.
Hmm.
So that drug holiday concept would be a total disaster here.
Strictly forbidden. You cannot take a drug holiday with denosumab. If a patient has to stop the injections, the physician has to execute a perfectly timed baton pass.
Meaning they immediately transition them to a bisphosphonate?
Yes, to chemically lock in the density gains they just achieved, you cannot just stop treatment.
The strategic foresight required for that is staggering.
Yeah.
But up to this point, every drug we've discussed is just defensive.
True. They just stop the demolition.
What about a patient who already has highly advanced osteoporosis? They've already suffered multiple vertebral fractures. Defending their fragile skeleton isn't enough. We need to actively build new bone.
And that requires crossing the threshold into the anabolics, the true bone builders. The primary agents here are parathyroid hormone analogs like teriparatide or abaloparatide.
Okay, let's pause here because this seems like a huge biological paradox to me. Doesn't parathyroid hormone normally leach calcium out of the bones?
It does. It's one of the most fascinating paradoxes in endocrinology. It all comes down to the frequency of the exposure.
What do you mean?
Well, if the skeleton is continuously exposed to elevated parathyroid hormone, it massively stimulates the osteoclasts, causing bone destruction. But researchers figured out that if you administer the hormone in a brief, daily, pulsatile spike,
Just a quick daily subcutaneous injection.
yes, that sudden pulse triggers a completely different biological pathway. It hyperstimulates the osteoblasts, the builders.
It forces the builders into overdrive, erecting vast amounts of fresh scaffolding.
Exactly. It dramatically increases bone mass in a way no defensive drug ever could.
The text shows massive decreases in fracture risk with these. But there is a glaring catch. A doctor is only allowed to prescribe these miracle builders for a strict maximum of 2 years. Why is there a ticking clock?
Because you are manipulating one of the most powerful biological levers in the body-forced rapid cellular growth. The 2-year limit is enforced by an FDA black box warning.
Because of cancer risks.
Right. During animal trials, prolonged continuous use in rats caused a dose-dependent increase in osteosarcoma, bone cancer.
So the very mechanism that makes it a miracle bone builder is what risks causing tumors if you leave it unchecked.
It is strictly a short-term rescue operation, and we see similar limitations with the newest builder mentioned in the source, an anti-sclerostin antibody called romosozumab.
Yeah, I noticed this one. It's almost like a double agent. The dosage is so big it needs 2 separate pre-filled syringes injected monthly.
And it does double duty. It's the only true dual-action therapy. It massively stimulates the builders while simultaneously suppressing the demolition crew.
Which sounds perfect, but again, there's a hard stop.
Right. Romosozumab is capped at a maximum of 12 months. After that, its bone-building effects just naturally plateau. But more importantly, it carries its own black box warning for an increased risk of severe cardiovascular events.
Like heart attacks and strokes.
Exactly.
So a patient does these intense injections, builds this pristine new skeleton for a year or two, and then the clock runs out. Doesn't all that new bone just immediately start getting demolished again?
It does, which is why anabolic therapies are only the first half of a relay race. The moment that clock expires, the doctor must seamlessly transition the patient to a powerful anti-resorptive agent.
You use the dangerous high-powered tools to build the house, and then instantly bring in the bisphosphonates or denosumab to put a shield around it.
That is the ultimate clinical strategy for severe osteoporosis.
It's wild. Okay, we've covered the main arsenal, but the textbook also highlights some weird outlier treatments. It really shows how individualized this field is. Take raloxifene, for example.
Raloxifene is brilliant for a very specific patient demographic. It's an estrogen agonist in bone tissue.
Meaning it acts exactly like estrogen, suppressing the osteoclasts and protecting the skeleton.
Right, but it acts as an estrogen antagonist in breast tissue, meaning it actively blocks estrogen receptors there.
Which makes it perfect for a postmenopausal woman who needs osteoporosis treatment, but also has a high risk of developing estrogen receptor-positive breast cancer.
Exactly. You protect the bones and reduce the cancer risks simultaneously. It only really prevents spinal fractures, though, and it can increase the risk of blood clots. But still, very elegant.
And then there's calcitonin, which frankly just reads like an anomaly. a daily nasal spray for bone density.
Calcitonin is a naturally occurring hormone that weakly inhibits bone resorption. But honestly, as a frontline treatment, it's relegated to last-line status today.
Because it's just so poor at reducing fracture risk compared to everything else.
Yeah, exactly.
Then why even include it in the clinical arsenal?
Because it possesses one highly unique non-structural benefit. It produces a distinct analgesic or pain-relieving effect specifically for acute bone pain.
Ooh. So if a patient presents in absolute agony from a freshly collapsed spinal vertebra,
A brief course of calcitonin nasal spray can provide really targeted pain relief while offering a mild baseline of skeletal defense. It's used for comfort, really, not architecture.
that makes total sense. Now, before we wrap up, there is a massive clinical red flag in this text we have to touch on. Glucocorticoid-induced osteoporosis. We're talking about patients taking common oral steroids, like prednisone.
This is arguably the most critical external threat to bone health we see. Steroids are a multi-front assault on the skeleton.
They attack everything, don't they?
They do. They directly inhibit the builders, they aggressively stimulate the demolition crew, and they actively block your gut from absorbing calcium.
A complete dismantling of the entire system. And the statistics in the text are just horrifying. For patients on long-term oral steroids, which is defined as just 2.5 milligrams of prednisone a day for 3 months.
The risk of a spinal fracture skyrockets to 40%.
40%. Nearly half of those patients will suffer a fractured spine just as a side effect of treating their asthma or rheumatoid arthritis.
Which completely shifts the medical strategy from reactive to preemptive.
You don't wait for a DEXA scan to show bone loss.
Absolutely not. If a patient over 40 is prescribed that kind of steroid regimen, the guidelines mandate preemptively placing them on an oral bisphosphonate.
You start the chemical defense before the steroids even touch the bone.
You have to anticipate the demolition and poison the crew before they even arrive on site.
It is a relentless tactical war. Let's recap this arsenal really quickly. You secure the raw materials with calcium and vitamin D. You deploy the frontline bisphosphonates using gravity and perfectly timed drug holidays to manage the toxicity.
Yep.
If that fails, you use denosumab to intercept the cellular work orders, knowing you can never, ever miss a dose. And for the most critical cases, you utilize the dangerous time-limited anabolics to frantically build new bone before handing the baton back to the defenders.
The pharmacological landscape here is just a masterpiece of biological manipulation.
It fundamentally changes how you view a skeleton.
It does. And actually, if we take this profound understanding of bone remodeling, this constant need for mechanical stress to trigger the builders, it raises a fascinating problem outside the clinic. Think about astronauts.
Wow. On the International Space Station or traveling to Mars. Zero gravity.
Right. In a microgravity environment, the skeleton experiences almost zero mechanical stress. The builders essentially go dormant because they don't feel the weight of the body demanding structural reinforcement.
But the demolition crew keeps working.
They keep working. Astronauts can lose up to 2% of their bone mass every single month they are in space.
That is staggering.
Figuring out how to manipulate these incredibly powerful pathways without gravity is literally one of the greatest hurdles to deep space exploration right now.
So the exact same molecular battles being fought in a rheumatology clinic are the hurdles keeping us from colonizing the solar system. The next time you picture a bone, don't just think of a rigid white line on an X-ray. Think of a bustling microscopic construction site that is constantly reacting, adapting, and never ever sleeps.